Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today, ICOS presents highlights from a recent webinar regarding clinical trials related to ATTR cardiomyopathy. We will hear from Dr. Michelle Kittleson of the Smidt Heart Institute at Cedars-Sinai in Los Angeles, California. Dr. Kittleson is a professor of medicine and is very involved in education on local, national, and international levels. In a clear and engaging presentation, Dr. Kittleson gives us an overview of clinical amyloidosis, followed by an in-depth review of previous, current, and future trials related to ATTR amyloid. If you are not a member of ICOS, please go to our website and join this fantastic and growing organization. Now let's enjoy Dr. Kittleson's presentation.
Thank you so much. Delighted to be here. Okay, very good. First test of the morning. Can I make sure these slides work? I'm delighted to dive in with a clinical trial update in ATTR cardiomyopathy. I have no disclosures. So before I get into the trials, just 30 seconds on amyloidosis. As we all know, it's a condition, cardiac amyloidosis, where there's a protein the body produces naturally that for reasons we don't understand decides to deposit it in the myocardium, resulting in a restrictive cardiomyopathy. The two most common sources of the amyloid protein will be the immunoglobulin light chains, AL cardiomyopathy, or the TTR protein, ATTR cardiomyopathy. And the TTR protein, in turn, can have one of two sources. It might be a mutation in the gene, that's the variant form, ATTR-VCM, or the wild-type form, ATTR wild-type cardiomyopathy. In the olden days, we used to call that senile cardiac amyloidosis, but that hurts people's feelings, so now we call it wild-type TTR cardiac amyloidosis. One of the major clues to the diagnosis is often that it doesn't just deposit in the heart. There are other extracardiac manifestations, neuropathy in all forms, nephropathy, particularly unique to AL, gastrointestinal involvement, and the musculoskeletal orthopedic issues predominantly in TTR. So when we think about diagnosis, it's so important to remember the 3 plus or minus 1 tests you may need to come up with the diagnosis. It starts with having those clinical clues and a high index of suspicion. Start with a monoclonal protein screen. If it is abnormal, do not pass go, do not collect 200. Tissue is the issue. Call your friendly hematologist like Dr. Landau and figure out what to biopsy. If it's negative, then you can do a technetium pyrophosphate scan. Huge, amazing advance, allowing for non-invasive diagnosis of TTR amyloidosis, followed by genetic testing to see if it's the variant or the wild type form. A few subtleties to the diagnostic algorithm. Number 1, remember that SPEP, UPEP are not as sensitive as immunofixation electrophoresis. So when you do your monoclonal protein screen, go for IFE. Second, when you biopsy something, remember that the fat pad we all memorized in medical school is not as sensitive, particularly for TTR. So the affected organ will be the gold standard. And finally, while the technetium scan is absolutely amazing, allowing for non-invasive diagnosis of TTR, it can only be interpreted accurately in the context of a negative monoclonal protein screen. So make sure you do the right tests in the right sequence. This is very nicely encapsulated in the 2022 heart failure guidelines. When we think about therapies for TTR amyloidosis, they follow a very pleasing pathophysiological order. First, the TTR protein is the problem, so you could stop production. You could do that by inhibiting TTR synthesis with a liver transplant, quite extreme in this day and age, or RNA silencing. And we have a lot of RNA silencers out there now, patisiran, vutrisiran, and eplontersen, now FDA approved, and then gene editing we'll talk a little bit about. Then you can take this TTR protein, which in all of our bodies is minding its own business, transporting things around. It transports things, minding its own business when it's in a happy, stable tetramer form. It only causes problems when it misfolds and turns into fibrils that deposit into tissue. So if you could stabilize it in the happy tetramer form, it won't cause any problems. And that's the principle behind the stabilizers, diflunicil, tafamidis, and now acoramidis. And then the most enticing form of therapy would be to suck the TTR out of tissues so you can reverse what's going on. Not quite ready for prime time, very weak data for doxycycline and TUDCA. However, we'll talk a little bit about the monoclonal antibodies. So tafamidis, bottom line, is a treatment that works for TTR amyloidosis. The classic ATTR ACT trial came out in 2018, published in the New England Journal in 2019. 441 patients, tafamidis versus placebo for 30 months, a shocking 13% absolute reduction in mortality, a reduction in heart failure hospitalizations. The data was so strong that less than a year after the trial came out, the FDA approved its use. Two important points. Look at that survival curve. See how it separates at 18 months? That makes sense. It doesn't reverse disease. It either slows or halts progression. So you have to be on it for a while before you see the benefit. Hence, the survival curves take a while to separate. Second important point from the subgroup analyses is that the greatest benefit is in the less sick patients, NYHA class 1 to 2. Another plug for early diagnosis, early initiation of therapy, so patients do better. Now we have a new TTR stabilizer on the block, acoramidis, the ATTRibute-CM trial just published in the New England Journal. Acoramidis versus placebo, 600 patients. Tafamidis was allowed after 12 months because it was FDA approved and you couldn't withhold good therapy, but not many patients were on it. They used a different primary endpoint. They used the win ratio, which was a composite endpoint of increasing hierarchy, but even the most important one we typically think of, death from any cause, cardiovascular related hospitalization, was better on acoramidis. Is it better than tafamidis? Is it worse than tafamidis? We can't answer that question. The patient populations were different. ATTRibute-CM enrolled less sick patients because we're all getting better at diagnosis. And what we can say, though, is they both work. So when acoramidis is FDA approved, ultimately the right answer for your patient will be whichever one they can afford. Now, when we think about diflunicil, has NSAID properties. It's not so impressive. In the day and age of tafamidis, acoramidis, what's the role of diflunicil? We actually look at the clinical trials, they're not impressive at all. We have some open label, we have some retrospective, we have one randomized trial, but that's in patients with neuropathy, and half stopped the study drug because of the NSAID-like properties. Bottom line, it's not well tolerated. We don't know how it works on cardiovascular endpoints. Really, its only role might be in those patients who, through financial toxicity from tafamidis, cannot afford to take it. So let's move on now to the silencers. These are these mRNA analogs that stop the protein from being produced. We have two studies, Apollo and NeuroTTR, and those patients with the variant form and neuropathy. And we know that it slows progression, which is why it's FDA approved for patients with ATTR variant form and neuropathy. What about in cardiomyopathy? There are some post-hoc or open label analyses of these patients who show that there is reduction in surrogate endpoints, so may offer some benefit in patients who happen to have cardiomyopathy. What about in trials dedicated to patients with cardiomyopathy? Well, the Endeavor trial was stopped early due to deaths in the treatment arm. Was it causal? Was it coincidental? We'll never know. Verruceren won't be mentioned anymore. Apollo B came out recently, and it showed in patients with cardiomyopathy, patisiran led to less decline in the 6-minute walk distance after 12 months. So, to my mind, the jury is still out. I'm not sure this data is quite compelling. In fact, the FDA agreed and in October declined to expand approval of patisiran for use in patients with cardiomyopathy because they felt that the less decline in 6-minute walk distance after 12 months in Apollo B was not impressive enough. I think they probably got it right. Is the juice worth the squeeze for a medicine you have to take intravenously every 3 weeks? But all hope is not lost. There are 2 trials in the works with endpoints of death and cardiovascular hospitalization, Cardio-Transform, Helios-B, study end dates coming up. So we should know more soon about where the silencers will fit in the clinical armamentarium for TTR cardiac amyloidosis. Well, so we put it all together. There's always heart failure therapies you may consider, though they're often poorly tolerated in patients with restrictive physiology due to their fixed stroke volume, reliance on heart rate, and intolerance to vasodilators. There's the arrhythmias you'll treat. But when it comes down to the cardiomyopathy, basically all we have currently is tafamidis for disease-directed therapy, and we need to know where all of these other things may fit in the algorithm. And in fact, the ACC/AHA 2022 heart failure guidelines tell us the strongest recommendation, class 1 indication, to give tafamidis TTR stabilizer therapy for patients with cardiac amyloidosis. But I can't resist a few glimpses into the future. The study on the figure on the left comes from a gene editing study that appeared in the New England Journal, where you send an mRNA for TTR into liver cells to alter the TTR DNA, allowing permanent silencing of TTR production, potential for repair in the future. In this proof of concept study, there was effective knockdown of the TTR protein. I mean, that's exciting conceptually because gene editing is exciting, but it's basically like a permanent form of patisiran or vutrisiran or eplontersen. I'm far more excited by the figure on the right, which I think is a game changer. This is a study about a monoclonal antibody that binds only to the misfolded TTR fibrils, so it allows antibody-mediated phagocytosis and removal from tissues. Potential to, this is the holy grail, reverse ATTR cardiomyopathy. And in this analysis, 40 patients, they had imaging, they had biomarkers, and there was a reduction in the imaging-based surrogate markers of cardiac amyloid load. Studies ongoing so we can learn more about safety and clinical efficacy. So a bird's eye view, I think it's really extraordinary where the field has gone. I graduated from medical school 25 years ago this year. And when I was in medical school, we learned about amyloidosis and we promptly forgot about it because you couldn't do anything about it. But look at the renaissance over the past decade in our ability to diagnose and treat cardiac amyloidosis. I think the best is yet to come. So what do we know? We know that it's more common than you think, have a high index of suspicion. We know that non-invasive diagnosis is possible, but remember, you must interpret your pyrophosphate scan in the presence of a negative screen for monoclonal proteins, and that tafamidis is currently our only effective evidence-based therapy. We need to know if the silencers are going to work, if standard of care will be a stabilizer plus a silencer, or if we can tailor it to the individual patient. We need to know how to assess response to therapy, and more importantly, what would we do with the non-responders? And what happens when we get too good at diagnosis? How should these asymptomatic patients be managed? And of course, a diagnosis of cardiac amyloidosis would not be complete without a mention of the elephant in the room, which is cost. And while our dedication must be to every patient sitting in front of us in clinic to do the best we can on a patient by patient level, we also, I think, have an obligation as a society to do our best by our healthcare community, because it's not just great science that saves lives, it's great science plus effective implementation that equals lives saved. So hopefully we can do something as a community to help our patients with their financial toxicity. Thanks so much for your attention. That's all I had to say.
What an excellent and energetic presentation that brings us all up to date on ATTR cardiomyopathy and also gives us more hope for future treatments. Don't forget to visit the ICOS website for information on all topics related to cardio-oncology at ic-os.org. We hope you enjoyed this presentation and remind you to treat cancer, protect hearts.